Hi, so as Alicia said, I'm Krystal. I'm from Advanced Care Pharmacy. I've been there about 4 years now, and I'm sure I've talked to a lot of you on the phone, but it's always nice to come out and put faces to the names. So I'm happy to be here. I'm going to be talking about methadone, both in general and specifically how it relates to practice in hospice. Is developing a methadone protocol something you guys are considering?
Yeah.
Okay.
Yes. So, yeah, go ahead.
Hopefully this will kind of give you information to decide one way or the other, and if you do decide to, give you kind of a jumping off point where to start on getting a protocol together. So first, just some objectives of the program. After the conclusion of my talk, you guys should all be able to describe the characteristics of methadone, including history, mechanism of action, pharmacokinetics, adverse reactions, and drug interactions. Also, you should be able to explain the utility of methadone for pain management in the hospice population. You'll want to be able to explain the appropriate dosing of methadone, including the available dosage forms, appropriate starting dose titration after it's been started up to effective dose, as well as monitoring parameters. You want to understand the advantages and disadvantages of methadone compared to its alternatives, the other long-acting pain regimens that are more conventional. And finally, describe the safe use of methadone in hospice and palliative care. So I started with a history of methadone just to give you guys some context about the drug. It was developed in Germany during World War II as a pain reliever for soldiers when they had a shortage of morphine. After the war, it was introduced into the U.S. in the late 40s and used for pain, but because not much was known about it, it was prescribed in very high doses that led to intolerable side effects, which was obviously not favorable. Then in the 60s, we saw the opening of methadone clinics that were used for the detoxification and maintenance of narcotic addicts after the resurgence of heroin as a street drug. Later in the 80s and 90s, MS-Contin, OxyContin, and Duragesic came to market, and these are, of course, the long-acting morphine and oxycodone. Just FYI, the Contin in those is for continuous release. That's how you can remember that those are the long-acting ones. And Duragesic is the brand name of the fentanyl patches. So these kind of replaced methadone as the long-acting drugs of choice for pain control, and methadone fell out of favor at that time. So since then, medical schools have not really provided a lot of training or education on using the drug for pain management to the doctors. So there's a lot of people out there who just really aren't familiar with how to use it for pain. So starting with some basic information about methadone, its mechanism of action is twofold. First, like all narcotic pain medications, it binds to the various opioid receptors where it acts as an agonist. This decreases the excitability of the nerves and in turn reduces the pain impulses that are sent to the brain, so the pain is dulled. However, methadone is also an NMDA receptor antagonist, which again, it decreases the excitability of nerves, but to a different end. In this way, it protects nerves and cells against death and destruction from overexcitation. It's been suggested that this novel mechanism of action for methadone is the reason that it may be superior to other pain medications in treating neuropathic pain, the kind of burning, tingling pain that you see with diabetic neuropathies or fibromyalgia that is a lot more difficult to treat. So next, talking about the pharmacokinetics, that refers to what the drug physically goes through in the body after it's been ingested and includes absorption, distribution, metabolism, and excretion. So methadone is absorbed orally at a rate of more than 80%, which is a fairly high bioavailability. After it's been taken, it begins to work in about 30 to 60 minutes. However, peak pain relief doesn't occur until about the 3 or 4 hour mark. Methadone is metabolized by the liver to inactive metabolites, which makes it safer for use in patients with kidney disease, where things like morphine might not be the best choice. Its duration of action is 6 to 12 hours, and its half-life has been reported all over the map, anywhere from 4 to 190 hours, which is not only long but also extremely variable. This isn't because sources can't agree on what the half-life is, it's because the half-life differs so much person to person. Finally, methadone is excreted mainly in the feces, which is unlike any other opioid, and then to a lesser extent in the urine. So I want to go back to that concept of half-life. This is the most interesting, but is also the most problematic of the properties of methadone. The half-life is the time it takes for the body to eliminate 50% of the drug that was administered. And as I mentioned, various sources have reported this for methadone anywhere from 4 hours to 190 hours. Most importantly, to take away from that is there's no way to predict where on the spectrum any particular patient will be. So you can't say we have a healthy 20-year-old versus a end-stage cancer patient who's 90. That's completely independent of age, size, disease state. There's no way to tell how fast or slow someone's going to metabolize methadone. So this is not seen in any other pain medication, and it's also longer than most drugs. And all of this leads to a lot of difficulties in dosing methadone. There will be somebody who can eliminate the drug in a few hours, and some will take several days. Therefore, frequent dosage adjustments are required when initiating methadone therapy in a patient, and the effective dose varies greatly, anywhere from 2.5 milligrams a day to, I think we have a patient now on 80 milligrams 3 times a day. It's a huge range. Levels may accumulate to toxic levels because it hangs around in the body for so long, so you want to be aware of that. And the drug remains in the body for days to weeks after discontinuation. Another important point is overdose is difficult to treat because it does stay in the body for so long. It's not like morphine or a street drug like heroin where you can give Narcan and immediately reverse the effect. Just a quick comment on the adverse reactions to methadone. They're similar to all the pain medications that we deal with on a day-to-day basis and include constipation, nausea, sedation, itching, confusion, delirium, hallucinations, and of course the respiratory depression. However, it is interesting with methadone that many sources suggest the confusion, delirium, hallucinations, the sort of euphoric or dysphoric feelings that a lot of patients are uncomfortable with. A lot of sources say that this is less with methadone, less than with conventional opioids. There is sort of a unique adverse reaction that's possible with methadone. It is the development of Torsades de pointe, which is a potentially fatal ventricular arrhythmia characterized by an increased QT interval when you see it on the EKG. In methadone clinics, they suggest getting an EKG on a patient before starting methadone. I don't think that's particularly relevant in our practice, but it's an option out there if a patient is reluctant or doesn't want to take the additional risk. So methadone increases the risk for this arrhythmia. However, the incidence is still very, very small. It's a very rare side effect and almost always occurs in patients that have additional risk factors for the arrhythmia. That's things like structural heart disease, low magnesium or low potassium, and then most importantly, other medications that increase the QT interval. So these are ones that the ones I've included are ones that I see prescribed a lot for hospice patients. It's not an inclusive list, but they include things like amiodarone, amitriptyline, azithromycin, which is the Z-Pak, citalopram, diphenhydramine, haloperidol, which almost all of our patients at least have on hand in the e-kit, loratadine, olanzapine, and quetiapine. So in patients with these extra risk factors, if you do choose to start methadone, you want to use extra caution and extremely low doses. Methadone does have a lot of clinically significant drug interactions, which stems from the fact that it is metabolized in the liver by the cytochrome P450 enzyme. This enzyme breaks down a lot of drugs that are metabolized in the liver, so when there's more than one of these, they kind of compete for the metabolism, and one of them inevitably stays around in the body longer while the other one gets metabolized, and it's sort of waiting around for the enzyme to get to it and break it down. So again, this list is not comprehensive, but I've included the ones that we see most frequently in our population. Amiodarone and amitriptyline, you'll notice, are on both lists. They increase the QT interval and increase methadone levels. So patients that we can't get off those two medications may not be good candidates for methadone therapy. Other drugs that increase methadone levels due to the metabolism are Cipro, diazepam, diltiazem, fluconazole, fluoxetine, metronidazole, paroxetine, and tramadol. On the other hand, some drugs decrease methadone levels. They will sort of push methadone to the front of the line to be metabolized, and that would be things like the anti-epileptics, carbamazepine, phenobarbital, and phenytoin, as well as risperidol and spironolactone. So thus far, that was kind of an overview of methadone in general, and now we're going to talk more specifically about how it relates to hospice practice. These are some of the common reasons you'd consider starting methadone in one of our patients. First, when they are just starting out a routine long-acting opioid, which we would do when the PRN pain medications are no longer controlling the patient's pain. And a second indication for starting methadone would be when the current pain regimen is problematic for one of several reasons. One being high dose, maybe the tablet burden is just too much, or the frequency becomes every hour or every 2 hours, and it's not feasible for the caregiver to keep up with it. A second reason would be high cost of the current drug. Maybe they're on a huge dose of fentanyl patches or extended release oxycodone, which is very expensive. Even Cadian, which is the once-a-day capsule form of morphine, is I think around $15, $20 a capsule. So high cost is definitely a good reason to consider switching to methadone. Next would be if the patient has intolerable side effects on their current regimen, if their nausea or confusion or constipation becomes unmanageable, it's possible methadone would not have the same severity of side effects. And finally, if the current pain regimen is not providing adequate pain control for the patient, even though doses keep escalating, you keep increasing the morphine or oxycodone, and they're still not getting relief. This is especially true with the patients with neuropathic pain. That comes from that NMD receptor antagonism that makes it unique among the narcotics. So just a couple comments on requirements and restrictions. I wanted to make clear that any physician with a DEA license to prescribe controlled substances can prescribe methadone for pain. We will probably add the phrase "for pain" onto the prescription just to make it very clear what the purpose of the medication is, because there is special licensing and training required for any physician who prescribes methadone for addiction, whether to other painkillers or heroin, but that's usually the people who are in an inpatient facility or an outpatient clinic program. When used in hospice, methadone should be used only by experienced prescribers. It requires close and frequent monitoring and supervision, which will probably fall to you guys, and the complexities of the drug must be fully understood. So I want to talk about the dosing of methadone for a few minutes. It tends to be one of the more difficult medications to dose, and start low, go slow is kind of the overriding concept of how to dose this medication. This is due to its unique pharmacokinetics that we talked about, and we have to start low to avoid toxicity, and we go slow because we don't know how fast or slow the patient is going to metabolize the drug. The available dosage forms of methadone are tablets, which are immediate release. They come only in 5 and 10 milligrams, and also the liquid, which is very concentrated at 10 milligrams per milliliter. For this reason, caregivers will need to be educated if they are going to be administering the liquid methadone. They need to be familiar with the 1 ml oral syringe and how small the amount will actually be. Sometimes it's as low as 0.125 milliliters, so they need to recognize how small of an amount that is, and because overdose would be very easy to happen with a liquid that concentrated. On the other hand, an advantage of how concentrated this is that it's the only long-acting pain medication available as a liquid. There's no such thing as long-acting Roxanol or long-acting oxycodone liquid, so those would need to be dosed every hour, every 2 hours, every 4 hours, whereas this, can go every 12. It's also a great choice for sublingual administration because it is such a tiny amount. We're talking about typically less than a milliliter per dose. There is no direct conversion from other opioids to methadone, which is a question I get all the time, and it's unfortunate. However, we can't say, okay, this patient takes 90 milligrams of morphine a day, what is their equivalent methadone dose? There's no equivalent dose due to the half-life issues that we talked about earlier. So when you want to start methadone, for one of the reasons we talked about, you would DC the current long-acting opioid, whether it's morphine or oxycodone or something else, and start methadone at a dose of 2.5 or 5 milligrams, and that can be dosed QD to BID. You maybe start with 2.5 a day for a very frail elderly patient who is naive to narcotic medications, and then on the other end, you could go 5 milligrams twice a day on maybe a younger patient who's already on a high dose of narcotics. So because of the relatively slow onset and long half-life, methadone takes 3 to 5 days to reach steady state, which is when the drug is at a fairly consistent level in the body. Is what's coming in is the same as what's coming out. For this reason, methadone's not useful for acute pain. It's not going to treat something that comes up out of the blue. It's also not going to provide relief, within 30 minutes to an hour. It takes a while for methadone to build up in the body and take its full effect. And again, wide variation patient to patient. So when we're starting and titrating methadone, you want to keep breakthrough pain medication, probably MSIR or Roxanol, available throughout the whole titration. We do have to wait the 3 to 5 days to begin to determine if the current dose is appropriate, safe, and effective for that patient. So basically, as we titrate the patient up from their starting dose, we need to check in about every 3 days or so to determine if the dose is safe, if it's not causing too many side effects, and if it is in fact managing pain. The titration start is approximately every 3 days, and if the patient has required 3 or more doses of their breakthrough medication in any one day, that's when they would be a candidate to increase the methadone. You don't want to go any faster than doubling their previous dose. For instance, if they're taking 5 milligrams twice a day, you don't want to go any higher than 10 milligrams twice a day. Even that's pretty quick. Usually you go up by 2.5 or 5 milligrams a day. Also, we don't want to give it more frequently than 3 times a day. There is no maximum dose for methadone for pain, so even if it's at a high dose but the side effects are tolerable, there's no limit to how high you can go to treat pain. And finally, if the methadone is discontinued, which isn't very common for our patients, once they're titrated up, they tend to stay on that maintenance dose. However, methadone will remain in the patient's system until it's fully metabolized for a few days to a few weeks. Next slide is just a comment on cost to show you guys the great variability in cost of these long-acting narcotics. Methadone is by far the cheapest option, especially versus oxycodone. The doses, as doses get higher, prices get higher. Although one to point out is that oxycodone ER 20 milligrams is actually more expensive than the 40 milligrams. I did want to mention that our pricing model at Advanced Care is somewhat unique in that we base our price on our cost versus the average wholesaler price. This benefits everybody in the long run, but it also means there's a lot of fluctuation in our prices. I think Miriam said she checks them about once a week. And so these numbers are current as of Sunday night. They may go up or down, a few dollars here and there, but in general, methadone is much less expensive than high doses of the other long-acting narcotics. So in light of everything we've talked about so far, I just wanted to summarize everything in the form of the advantages and disadvantages of methadone to kind of help you guys come to a decision on if it would be a good thing to use in your practice. So advantages. Most importantly, it is potentially more effective for some patients and in certain situations. Its pain relief has been reported to be superior to that of morphine and oxycodone in some patients for no real apparent reason. This may most often be the case with patients with the neuropathic pain. However, typical pain presentation can be more effectively treated with methadone as well. Next, there's the favorable metabolism of methadone. It has no active or toxic metabolites, and it is processed in the liver, so it's safer for patients with kidney disease. And at the age of most of our patients, a lot of them have some kidney dysfunction, and in that case, morphine is not considered the best choice. It might also be a good option when the patient's not tolerating their other opioid well. For instance, if constipation becomes unbearable despite all the interventions, maybe switching to methadone would be a good idea. In addition, there's that lower incidence of hallucinations, dysphoria, and confusion, which will be helpful to patients and families as well. Obviously, people don't want to see those kind of things happening. Another advantage is the concentrated liquid dosage form. It's the only long-acting liquid pain medication, which is a huge advantage, and it's easily administered sublingually at 10 milligrams per milliliter. So again, we're talking about a once or twice daily dosage of a milliliter or less typically. And finally, our favorite, it is less expensive than the other alternatives. So all of that sounds really great, and you start to wonder why all your patients aren't on methadone for pain control, and that is because there are also a lot of significant disadvantages to using it. As we discussed, it's difficult and dangerous to dose. The long and variable half-life means that coming to a safe and effective dose for an individual patient requires a lot of trial and error. For example, one patient may metabolize a dose of methadone in a couple of days. A patient of similar size and health status may take a month to metabolize that same dose. It's also very labor intensive, as a nursing visit is required about every 3 days or so for monitoring throughout the dose titration process, which is obviously not the case for titrating any other narcotic up. As I mentioned, there is no simple mathematical conversion from a patient's current pain med regimen to methadone, which further complicates things. For all these reasons, dosing methadone requires specialized protocols that can only be developed and utilized by experienced practitioners, and even more caution is necessary in the elderly, which is, the majority of our patients. Next, there is the risk of overdose. There is cumulative toxicity due to the long half-life. In other words, it takes so long for the body to metabolize methadone that it can build up to kind of sneak up on you to overdose levels. In addition, Narcan is not an effective antidote for methadone overdose like it is for other medications, and so methadone overdose cannot be easily reversed once it's occurred. We also talked about the numerous drug interactions that affect methadone, and many of our patients are on one of these medications. They include common drugs like diazepam, fluoxetine, and Risperdal. We mentioned the risk of torsades de pointe, which, although small, does still exist when patients are taking methadone. And finally, there are some common misconceptions that may cause problems with caregivers or the patients themselves regarding methadone. They may think it's only for addicts or that it's only available at a clinic. So you may want to gauge their reaction when you say the word methadone to see if that's something that they would even be open to. so that is what I have on methadone for you. Are there any questions? Yes?
Because it is metabolized in the liver, is it contraindicated for patients with liver disease or liver cancer?
It's not. It can be used, it just at a lower dose. I think they recommend a 30% dose reduction. So being that we start dosing methadone so low anyway, you probably start at 2.5 milligrams a day and then continue to titrate similar to any other patient.
And then the medication for sublingual, can that be crushed and is that quickly absorbed, dissolves fast or?
The tablets?
Yeah, the
If you were to
tablets.
crush the tablets, I mean, it's a medium-sized tablet, so I can't imagine it would be absorbed fully under the tongue. At that point, we'd probably just recommend going to the liquid.
Okay, I just wanted to
Sure.
know on that.
Is there a big price difference between the tablets?
Not a lot, and I did realize that as I was looking through this last night that I didn't include the liquid, but 15 milliliters of methadone, which if you're dosing at 5 milligrams twice a day, that's a 2-week supply, is around $30. So very similar.
Yeah.
Any other questions?
You mentioned about constipation being, a side effect from a different opioid and maybe that will be considered to use methadone. I guess I'm just wondering, is it less insult on the intestines? Is that why, or gentler on the intestines?
I think it has to do more with the double mechanism of action. It's not only going against those opioid receptors. And also it has to do with opioid rotation. In general, if you switch from one to another, whether it's methadone or not, the side effects will be lower for a while. Yeah, exactly.
Got it.
Okay, I've got a little quiz for you guys. I figured we could take, oh, sure.
I was just waiting till people
Oh,
finish
of course.
questions, but are you able to share generally with hospices, since you guys service so many hospices, are you seeing in today's practice that a lot of hospices are using methadone for their patients, that it's a generally accepted hospice med?
I would say it's definitely not a majority that use it.
It's not,
It's,
okay.
but those who do adore it. They love it. It is difficult at the beginning, but once you get the patient where they need to be, the patients are generally happier, the results are better. It's just kind of all the work that has to go into it at the beginning that makes people shy away from it, I think. And also the education that has to come along with using it. But some of our bigger hospices use it. We service over 100, and I'd say maybe 15 to 20 use methadone regularly. All right, number 1, what is the mechanism of action of methadone? Opioid receptor agonist, NMDA receptor antagonist, A and B, or none of the above?
A and B.
Correct.
Yay, Fran!
The answer is C, both A and B. That's the reason it's possibly more effective against neuropathic pain, as well as pain that isn't treated by more conventional narcotics. How long after taking a dose of methadone will a patient experience the maximum pain relief? That's right, 4 hours, so not nearly as quickly as some of the other ones. However, makes it easier to do a more long-term dose every 12 hours or so. Number 3, which of the following is not a consequence of methadone's variable half-life? Frequent dose adjustments, variation of effective doses, potential toxic accumulation, or simple reversal of overdose. Right, there's no way to simply or easily reverse methadone overdose. Number 4, which of the following will not increase the risk of torsades de pointe? Right, the other 3 will definitely increase the risk.
I hung a Benadryl on him. I didn't like that family at all.
Number 5, which of the following medications will decrease the effectiveness of methadone?
B.
It is B, carbamazepine. this is due to the cytochrome P450 metabolism that we talked about. Number 6, what would be a good reason to start patient on methadone? Good pain control, no side effects, low cost, or unresolved neuropathic pain.
D.
Yeah, kind of an easy one. Number 7, does a prescriber need a special license to dispense methadone for chronic pain?
No.
Yeah.
Yeah.
No.
No.
Not at all.
D.
Not at all. Not at all. They only need a special license for addiction.
Oh.
Chronic
Okay.
pain doesn't mean you're
Only
addicted.
for the clinic.
That's correct. The answer is A. They do need a special license for treating addicts in a methadone clinic, but when it's prescribed for pain, just your typical DEA license will cover it, just like prescribing morphine or anything else.
So DEA is a normal license.
It is.
Oh.
You have to pay for it to have it. The doctors have to pay for it. But it's not a special addiction.
I guess I could have been
Prescription
more
writing
clear
was-
on the question. That's my fault.
No, she just graduated, so she's used to those
Right.
question challenges, with her instructors. You're doing fine, Dr. Krystal.
Thank you. Number
You'll get
8.
over that eventually.
Number 8, which of the following would not be an appropriate starting dose of methadone? 2.5 milligrams daily,
C.
twice a day, 3 times a day, or 5 milligrams twice a day.
C.
Well, I think D.
I did too.
Yeah.
C.
I can see why CTID isn't a good thing when we're talking about 12-hour dosing,
Mhm.
but I certainly think that 5 twice a day is worse.
Absolutely.
Yes.
So,
My answer was C.
I picked D as well.
But I can see where you're coming from on that as well.
Very prohibitive.
If I got a call for a doctor wanting to start methadone at TID, I would say no.
and what would you say to the doctor who said 5 twice a day?
I would ask for a rationale.
So you said no straight out,
Oh, now she's
but
arguing.
then you
with the
asked for
past
rationale.
comment. I'm just kidding.
I just graduated from school. Okay, so it's the TID portion, I guess.
C.
It's,
Yes.
Exactly.
okay, Claire, thank you.
Sorry,
You're not-
guys, I don't want to
you're not
start
even in my
any
study
trouble
group.
here.
Okay, C it is.
Number 9, which of these pain medications is the most expensive long term?
I know, I'm right on this one.
Morphine, oxycodone, methadone, or fentanyl?
B.
B. Yeah, the oxycodone, even though it is available generic now, it's still very, very expensive and probably can find a better alternative. And finally, which of the following is a disadvantage of using methadone? It's numerous drug interactions, higher incidence of side effects, lack of a liquid formulation, or ineffective against neuropathic pain.
Okay.
Right. The other 3 are all false. It has lower side effects, there is liquid formulation, and it is effective against neuropathic pain.